Greetings to all aspiring healthcare professionals and educators joining us from across the globe. I am Dr. Rashid, and it's my distinct pleasure to welcome you to our comprehensive and interdisciplinary journey through human anatomy. Each lecture in this series will be meticulously crafted to provide you with a holistic understanding of human anatomy by empowering you to excel in your respective fields and make meaningful contributions to the advancement of healthcare. Welcome to the Integrated Human Anatomy lecture series. Let's get started with lecture 1, Abdomen. Anterior abdominal wall. Nine region is divided topographically by two transverse and two longitudinal planes, right and left hypochondric, epigastric, right and left lumbar, umbilical, right and left inguinal, and hypogastric, pubic, which can be seen in the figure. Here we can see epigastric region, we have hypochondric region, left hypochondric region, umbilical region, right lumbar region, left lumbar region, right inguinal region, hypogastric region or pubic region, and left inguinal region. It is also divided by vertical and horizontal planes through umbilicus into four quadrants that are right and left upper quadrants and right and left lower quadrants. Umbilicus lies at level of intervertebral disc between third and fourth lumbar vertebrae, and its region is innervated by a 10th thoracic nerve. So this is the planes of subdivision of abdomen. Muscles of anterior abdominal wall. Three flat muscles of anterior abdominal wall are external oblique muscle, internal oblique muscle, transverse abdominis. Two vertical muscles of anterior abdominal wall are rectus abdominis and pyramidalis. Fascia and ligaments of anterior abdominal wall is located between skin and muscles of anterior abdominal wall. Superficial fascia is composed of two layers. The first one is the superficial fatty layer or camper fascia and deep membranous layer or scarpa fascia. Superficial fascia of anterior abdominal wall. Superficial fatty layer of superficial fascia is continuous with superficial fascia of thigh, continues over pubis and perineum as superficial perineal fascia. Deep membranous layer of superficial fascia is attached to fascia lata just below inguinal ligament. In midline, it fuses with linea alba and pubic symphysis, continues over penis as superficial fascia, and over scrotum as tortus tunic, which contains smooth muscle. Becomes continuous with superficial fascia of perineum, called as fascia. In females, it continues into labia majora. They contain extravasated urine and or blood between this fascia and deep fascia of abdomen, resulting from rupture of spongy urethra. Deep fascia covers abdominal muscles and continues over spermatic cord at superficial inguinal ring as external spermatic fascia. Linea alba is tendinous median raphe between two rectus abdominis muscles formed by fusion of aponeurosis of external oblique, internal oblique, and transverse abdominal muscles. Extends from xiphoid process to pubic symphysis, and in pregnancy it becomes pigmented vertical line, linea nigra, probably as a result of hormone stimulation to produce more melanin. We can see in the figure fatty layer that is campers and membranous layer that is scarpus, superficial fascia, and other parietal peritoneum, as well as the visceral peritoneum. And also the muscles, external oblique muscle, internal oblique muscle, transverse abdominis muscle. Linea semilunaris is curved line along lateral border of rectus abdominis muscle. Linea semicircularis, that is arcuate line, is crescent-shaped line making an inferior limit of posterior layer of rectus sheath just below level of iliac crest. Lacnular ligament or Gimbernert ligament represents medial triangular expansion of inguinal ligament to pectinal line of pubis, forms medial border of femoral ring and floor of inguinal canal. Pectinal copper ligament is strong fibrous band that extends laterally from lacunar ligament along pectinal line of pubis. Inguinal ligament or purpurate ligament is folded lower border of aponeurosis of external oblique muscle that extends from anterior superior iliac spine to pubic tubercle, forms floor, inferior wall of inguinal canal. Iliopectinal arcus or ligament is fascial partition that separates muscular lateral and vertical medial lacunae deep to inguinal ligament. Muscular lacuna transmits iliopsoas muscles. Vascular lacuna transmits femoral sheath and its contents, including femoral vessels, femoral branch of genitofemoral nerve, and femoral canal. Reflected inguinal ligament is formed by fibers derived from medial portion of inguinal ligament and lacunar ligament and run upward over conjoint tendon to end at linea alba. Falx Inguinalis or conjoint tendon is formed by aponeurosis of internal oblique and transverse abdominal muscles and inserts into pubic tubercle and crest. We can see that here we have rectus abdominis muscle, we have the skin, we have the peritoneum, we have the falciform ligament, we have posterior layer of rectus sheet, transveralis fascia, we have external, internal and transverse abdominis muscles. Again, you can see the peritoneum, we have the umbilical perivesical fascia, we have a transversalis fascia. So strengthens posterior wall of medial half of inguinal canal. Rectus sheet is formed by fusion of aponeurosis of external oblique, internal oblique, and transverse abdominis muscles of abdomen, inclusive rectus abdominis and sometimes pyramidalis muscle. Also contains superior and inferior epigastric vessels and ventral primary MI of thoracic nerves 7 to 12. Anterior layer of rectus sheet above arcuate line, aponeurosis of external internal oblique muscles. Below arcuate line, aponeurosis of external oblique, internal oblique, and transverse abdominis muscles. Posterior layer of rectus sheet above arcuate line, aponeurosis of internal oblique and transverse abdominis muscles. Below arcuate line, posterior rectus sheet is absent and rectus abdominis is in contact with transversalis fascia. And here we can see the arrangement of rectus sheet above umbilicus, top, and below arcuate line, that is bottom. Inguinal or Hasselbalch triangle is bounded immediately by linea semilunaris, rectus abdominis lateral edge, laterally by inferior epigastric vessel, and inferiorly by inguinal ligament. We can see in this figure, we have deep inguinal ring, we have aponeurosis of external oblique muscle, we have linea alba, we have external oblique muscle, we have the spermatic cord, we have an inguinal ligament, we have a superficial inguinal ring, we have anterior superior iliac spine. Direct inguinal hernia protrudes through abdominal wall through inguinal triangle medial to inferior epigastric vessels. Inguinal rings are superficial inguinal rings, is triangular opening in aponeurosis of external oblique muscle that lies just lateral to pubic tubercle. Deep inguinal ring is an opening in transversalis fascia just lateral to inferior epigastric vessels. Inguinal canal begins at deep inguinal ring and terminates at superficial ring, transmits spermatic cord or round ligament of uterus and genital branch of genitofemoral nerve, both of which run also through deep inguinal ring and inguinal canal. We have four walls: anterior wall, posterior wall, superior wall, that's the roof, and inferior wall, that's the floor. Spermatic cord is composed of ductus deferens, testicular, cremastric, and differential arteries, pampiniform plexus of testicular veins, genital branch of genitofemoral and cremastric nerves, and testicular sympathetic plexus, and lymph vessels. These all are interconnected by loose connective tissue. Spermatic cord has several fascia, including external spermatic fascia, cremastric fascia, internal spermatic fascia, which can be seen in the figure also. Scrotum consists of thin, pigmented skin and dartos fascia, layer of smooth muscle fibers. When contracted, it wrinkles for testicular temperature regulation. Scrotum is innervated by genital branch of genitofemoral, anterior scrotal branch of ilioinguinal, posterior scrotal branch of perineal, and perineal branch of posterior femoral cutaneous nerves. It receives blood from anterior scrotal branches of external pudendal artery and posterior scrotal branches of internal pudendal artery. Lymph from scrotum drains into superficial inguinal nodes. Testes are surrounded by tunica vaginalis in scrotum, produce sperm in semifibrous tubules, and interstitial cells of lytic produce testosterone, are innervated by autonomic nerves, receive blood from testicular arteries rising from aorta, and drain venous blood to by testicular veins, which empty into inferior vena cava on right and renal vein on left. Lymphatic drainage follows the testicular arteries into lumbar or aortic nodes. Figure A showing the covering of spermatic cord and testes, and the B is showing the inguinal hernia. Inner surface of anterior abdominal wall, umbilical folds or ligaments. Median umbilical ligaments or fold is fibrous cord-like remnant of obliterated arcus covered by peritoneum, lies between transversalis fascia and peritoneum, extends from apex obliter to umbilicus. Then we have medial umbilical ligament or fold. Then we have lateral umbilical fold, supravesicular fossa, medial inguinal fossa, lateral inguinal fossa, transversalis fascia. And we can see also in the figure that we have falciform ligament, lateral umbilical cord, medial umbilical cord also, femoral nerve, external vessels, urinary bladder, seminal vesicle, prostate, bulbourethral gland, urethra, obturator nerve and vessel, ductus deferens, inferior epigastric vessels, ductus abdominis muscle, arcuate line, umbilicus region, round ligament of liver and para-umbilical vein, diaphragm, and also we can see here transversalis fascia, anterior superior spine, inguinal ligament, deep inguinal ring, inferior epigastric artery, somatic cord, and pubic symphysis, as well as femoral artery and vein. Nerves of anterior abdominal wall are subcostal nerve, iliohypogastric nerve, ilioinguinal nerve. We can see here We have the lateral cutaneous branch of subcostal nerve. Then we have iliohypogastric nerve, and then we have the ilioinguinal nerve. Lymphatic drainage of anterior abdominal wall. Lymphatics in region above umbilicus drain into the axillary lymph nodes. Lymphatics in region below umbilicus are drained into superficial inguinal lymph nodes. Superficial inguinal lymph nodes receive lymph from lower abdominal wall, buttocks, penis, scrotum, labium majus, and lower parts of vagina and anal canal. Their efferent vessels primarily enter external iliac nodes and ultimately lumbar aortic nodes. Blood vessels of anterior abdominal wall, superior epigastric artery. We have inferior epigastric artery, deep circumflex iliac artery, which can be seen here. So we have superior epigastric artery, deep circumflex iliac artery, superficial circumflex iliac artery, superficial epigastric artery, superficial circumflex iliac artery, as can be seen in the figure, superficial external pudendal artery, then thoracoepigastric veins. Then we have peritoneum and peritoneal cavity. Peritoneum is serous membrane lined by mesothelial cells. Parietal peritoneum lines abdominal and pelvic walls and inferior surface of diaphragm, is innervated by somatic nerves such as phrenic, lower incostal, subcostal, iliohypogastric, and ilioinguinal nerves. Then we have visceral peritoneum that covers viscera, is innervated by visceral nerves and is insensitive to pain. Then we can see A and B. We have intraperitoneal, and in the B we can see the retroperitoneal. Peritoneal reflections support viscera and provide pathways for associated neurovascular function. Structures omentum is fold of peritoneum extending from stomach to adjacent abdominal organ, as can be seen in the figure. Lesser omentum is double layer of peritoneum extending from porta hepatis of liver to lesser curvature of stomach and beginning of duodenum. Consists of hepatogastric and hepatoduodenal ligaments and forms anterior wall of lesser sac of peritoneal cavity. Transmits left and right gastric vessels which run between its two layers along lesser curvature of stomach. Contains proper hepatic artery, bile duct, and portal vein with its right free margin. In the figure, we can see the sagittal section of abdomen. Greater omentum hangs down like apron from greater curvature of stomach, covering transverse colon and other abdominal viscera, can prevent loops of small intestine from passing into herniated sac by plugging the entrance, transmits right and left gastroepipelic vessels and along greater curvature, wraps and adheres around inflamed abdominal organs, thus preventing serious diffuse peritonitis. Peritonitis is basically inflammation of peritoneum characterized by accumulation of peritoneal fluid that contains fibrin and leukocytes. Plus, that's the pathology. Has following subdivisions. So greater omentum, first division is gastrolineal or gastrosplenic ligament. Other is lineorenal or splenorenal ligament, gastrophrenic ligament, gastrocolic ligament. Mesenteries of small intestine, also known as mesentery proper, is a fan-shaped double fold of peritoneum that suspends jejunum and ileum from posterior abdominal wall and transmits nerves and blood vessels to and from small intestine. Forms root that extends from duodenal flexure to right iliac fossa and is approximately 50 centimeter or 6-inch long. Has free border that encloses small intestine, which is approximately 6 meter or 20 feet long. Contains superior mesenteric intestinal, jejunal, and ileal vessels, nerves, and lymphatics. We have transverse mesocolon, connects posterior surface of transverse colon to posterior abdominal wall, fuses with greater omentum to form gastrocolic ligament, contains middle colic vessels, nerves, and lymphatics. Then sigmoid mesocolon connects sigmoid colon to pelvic wall and contains sigmoid vessels. Its line of attachment may form innervated V. Mesoappendix connects appendix to mesentery of ileum and contains appendicular vessels. Other peritoneal ligaments include phrenicocholic ligament, falciform ligament, which is sickle-shaped periform peritoneal fold connecting liver to diaphragm and an anterior abdominal wall, contains ligamentum teres separatus and paraumbilical vein, which connects left branch of portal vein with subcutaneous vein in umbilicus region. Ligamentum teres separatus or round ligament of liver lies in free margin of falciform ligament, essence from umbilicus to inferior visceral surface of liver, lying in fissure that forms left boundary of quadrate lobe of liver, is remnant of left umbilical vein, which carries oxygenated blood from placenta to left branch of portal vein in fetus. Right umbilical vein is obliterated during embryonic period. Coronary ligament is peritoneal flexion from diaphragmatic surface of liver onto diaphragm and encloses triangular area of right lobe, bare area of liver, has right and left extensions from that form right and left triangular ligaments. Ligamentum venosum is fibrous remnant of ductus venosus, lies in fissure on inferior surface of liver, forming left boundary of caudate lobe of liver. Peritoneal folds are rectouterine fold and ileocecal fold. Rectouterine fold extend from cervix of uterus alongside of rectum to posterior pelvic wall, forming rectouterine pouch of Douglas. Ileocecal fold extends from terminal ileum to cecum. Peritoneal cavity is present space between parietal and visceral layers of peritoneum and contains film of fluid that replicates surface of peritoneum and facilitates free movement of viscera. Is completely closed sac in male and but is open in female through uterine tubes, uterus, and vagina. It is divided into lesser and greater sacs. Lateral sacs, ventral bursa, irregular shape space that lies behind liver, lesser omentum, stomach, and upper anterior part of greater omentum. Is closed sac except for its communication with greater sac through epiploic omental foramen or Winslow foramen. Presents three recesses: superior recess, which lies behind stomach, lesser omentum, and left lower liver; inferior recess, which lies behind stomach, extending into layers of greater omentum; splenic recess, which extends to left at hilum of spleen. Greater sac extends across entire breadth of abdomen and from diaphragm to pelvic floor and presents numerous recesses. We have subphrenic or suprahepatic recess, subhepatic recess or hepatorenal recess or Morrison pouch. We have paracloic recesses or Bouter's, epiploic or omentum with foramen, which is natural opening between lesser and greater sacs, is bounded superiorly by caudate lobe of liver, inferiorly by first part of duodenum, anteriorly by free edge of lesser omentum, and posteriorly by inferior by the cava. Esophagus, abdominal portion, is muscular tube, as can be seen in the figure. We have the esophagus here. It is 10 to 10 inches or 25 centimeter long that extends from pharynx to the stomach. Short abdominal port, half-inch long, extends from diaphragm to cardiac orifice of the stomach, entering abdomen through opening in right curves of diaphragm. This distal portion is located in epigastric region of abdomen. Upper esophageal sphincter is cricopharyngeus, part of inferior pharyngeal constrictor. Physiologic lower esophageal sphincter is circular layer of smooth muscle, a terminal portion of esophagus. As we can see here, we have upper esophageal sphincter, we have lower esophageal sphincter here. Tonic contraction of the sphincter prevents stomach contents from regurgitating into esophagus. In addition, diaphragmatic musculature forming esophageal hiatus functions as physiologic external esophageal sphincter. Stomach is posterior surface lies in shallow stomach bed, which is formed by pancreas, spleen, left kidney, left spinal gland, transverse mesocolon, and diaphragm. Potential space of lesser sac separates stomach bed from posterior surface of stomach, is covered entirely by peritoneum, and is located in left upper quadrant of abdomen, has greater and lesser curvatures, cardiac and pyloric openings, and cardiac and angular nodules. It's divided into four regions. We have cardia, then we have fundus, we have body, and then pylorus. Fundus lies inferior to apex of heart. Pylorus is divided into pyloric antrum and pyloric canal, as can be seen here. Pyloric antrum is here, pyloric canal is here. Pyloric orifice surrounded by pyloric sphincter, which is a group of thickened circular smooth muscles that control rate of discharge of stomach contents into duodenum. Sphincter is constricted by sympathetic stimulation and relaxed by parasympathetic action. Stomach receives blood from right and left gastric, right and left gastroepithoic and short gastric arteries. Internal surface of body and fundus has ruggy, longitudinal folds of mucous membrane. Within lesser curvature, mucosa is smoother, forming gastric canal that directs fluid towards pylorus, produces mucus, hydrochloric acid, pepsin, and hormone gastrin. Mucus protects stomach from separation. Hydrochloric acid destroys many organisms and provides required acidic environment for pepsin activity, which breaks down proteins into polypeptides. Gastrin stimulates gastric acid secretion. So parasympathetic fibers of vagus nerve also stimulate gastric secretion. This is are the images from abdomen computed tomography at different levels. We can see that we have fundus of stomach here. We have the superior part of duodenum. We have the gallbladder here. We have the descending part of duodenum. We have a transverse colon. Then we can see also pyloric antrum. We have the pylorus. We can see the body of stomach and the jejunum also. And the third part of the duodenum. That's the horizontal or third part of duodenum. Small intestine extends from pyloric opening to ileocecal junction, is location of complete digestion and absorption of most of products of digestion. Electrolytes and minerals such as calcium and iron consists of duodenum, jejunum, and ileum. Duodenum is C-shaped tube surrounding pancreas head and is shortest 25 centimeter or 10 inches long or 12 finger breadths in length, and widest part of small intestine is retroperitoneal except for first part, which is connected by to liver by hepatoduodenal ligament of lesser omentum, receives blood from celiac, foregut, and superior mesenteric midgut artery, is divided into four parts. Superior first part has mobile or free X section, termed duodenal cap because of its appearance on radiograph, to which pylorus invaginates. Descending or second part, junction of foregut and midgut lies just below major duodenal papilla, where common bile and main parenteral ducts open. Minor duodenal papilla, which lies 2 centimeter above major papilla, marks site of entry of accessory pancreatic duct. Then transverse or third part is longest part and crosses inferior vena cava, aorta, and vertebral column from right to left, is crossed anteriorly by superior mesenteric vessels. Ascending fourth part ascends to left of aorta to level of second lumbar vertebra and terminates at jejunal junction, which is fixed in position by suspensory ligament of teres. This fibromuscular band is attached to right crest of diaphragm. Then we have jejunum, lies between jejunum and ileum. We can see here the small intestine, three parts, jejunum, and ileum. We can see also cecum, we can see appendix, rectum, and colon. And also in this picture, you can see stomach, duodenum, and other parts of the small intestine. Is emptier, larger in diameter, and thicker wall than ileum, has piliae circularis, circular fold, which are tall and closely packed, has translucent areas called windows between blood vessels of its mesentery, has less prominent arterial arcades and anastomotic loops in its mesentery compared with ileum, has longer vasa recta, straight arteries or artery recti compared with ileum. Ileum is longer than jejunum and occupies iliac fossa in right lower quadrant of abdomen, is characterized by presence of paired patches, aggregations of lymphatic tissue, shorter piliae circularis and vasa recta, and more mesenteric fat and arterial arcades when compared with jejunum. Ileocecal fold, bloodless fold of Treves, is peritoneal fold located between ileum and cecum. Large intestine extends from ileocecal junction to anus and is approximately 1.5 meter to 5 feet long, consists of cecum, we can see in the figure, appendix, colon, rectum, and canal. We have cecum, appendix, then we can see also the colon and the anal canal and the rectum. Functions to convert liquid contents of ileum into semi-solid feces by absorbing water, salts, and electrolytes. It is also stored and duplicates feces with mucus. Colon has ascending and descending colons that are retroperitoneal and transverse and sigmoid colons that are surrounded by peritoneum. Transverse mesocolon and sigmoid mesocolon, respectively. Ascending and transverse colons are supplied by superior mesenteric artery and vagus nerves proximal to left colic splenic flexure. Descending and sigmoid colons are supplied by inferior mesenteric artery and pelvic splanchnic nerves. Large colon is characterized by following T. coli, three narrow bands of outer longitudinal muscular cord, scalutations, scalulations or hostra produced by tinea, which are slightly shorter than gut tube. Epiploic appendages, peritoneum covered sacs of fat attached in row along tinea coli. Cecum is blind and pouch of large intestine. It lies in right iliac fossa and is surrounded by peritoneum and has no mesentery. Appendix is narrow, hollow muscular tube with large aggregations of lymphatic tissue in its wall. Is suspended from terminal ileum by a small mesentery. Mesoappendix, which contains appendicular vessels, cause spasm and distension when inflamed, resulting in pain that is referred to periumbilical region and move down and to right. Has base that lies deep to McBurry point, which occurs at junction of lateral one-third of imaginary line between right, anterior, superior iliac spine, and umbilicus. This is the site of maximum tenderness in acute appendicitis, which is the pathology of appendix. Rectum and canal extends from sigmoid colon to anus, and we will describe during pelvic organs. We can see descending colon, we can see sigmoid colon, we have the rectum here and the anal canal. Accessory organs of the digestive system include liver, which is the largest visceral organ and largest gland in the human body, plays important role in production and secretion of bile, used in emulsification of fats, detoxification by filtering blood to remove bacteria and foreign particles that have gained entrance from intestine, storage of carbohydrates as glycogen to be broken down later to glucose, production and storage of lipids as triglycerides, plasma protein synthesis, albumin and globulin, production of blood coagulants, fibrinogen and prothrombin, anticoagulants, heparin, and bile pigments, bilirubin and bilirubin from breakdown of hemoglobin, reservoir of blood, and platelets, and storage of certain vitamins, iron, and copper. Liver is surrounded by peritoneum and attached to diaphragm by coronary, falciform, and right and left triangular ligaments, as can be seen in the figure. Has bare area divided of peritoneum on diaphragmatic surface, which is limited by layers of coronary ligament, receives oxygenated blood from hepatic artery and deoxygenated nutrient rich, sometimes toxic blood from portal vein. Venous blood is drained by hepatic veins into inferior vena cava. We can see here we have right lobe, left lobe, then we have the quadrate lobe, and then we have the other quadrate lobe here. Then we have a coronary ligament, hepatic veins, right triangular ligament, this caudate process, porta hepatis, caudate lobe, fissure of for teres ligament, proper hepatis artery, teres ligament, and also we can see here the gallbladder. So contains internal portal triad, which are branches of portal vein, hepatic artery, and bile duct at every corner of liver. Lobule is divided based on hepatic drainage and blood supply into right and left lobes by fossa for gallbladder and inferior vena cava. These lobes correspond to functional units or hepatic segments. Lobes of liver are further divided into 8 functionally independent segments. Each segment can be identified numerically or by name. Right lobe is divided into anterior and posterior segments, each of which is subdivided into superior and inferior areas of segments. Left lobe is divided into medial and lateral segments, each of which is subdivided into superior and inferior areas or segments. Quadrate lobe receives blood from left hepatic artery and drains bile into left hepatic duct. Caudate lobe receives blood from right and left hepatic arteries and drains bile into left hepatic duct. Fissures and ligaments of liver are arranged in H shape. Fissure or for round ligament is ligamentum teres hepatis, located between the lateral portion of left lobe and caudate lobe. Fissure for ligamentum venosum, located between caudate lobe and lateral portion of left lobe. Fossa of a gallbladder, located between caudate lobe and major part of right lobe. Fissure of inferior vena cava, located between caudate lobe and major part of right lobe. Porta hepatis is transverse fissure on visceral surface of liver between caudate and caudate lobes. It contains hepatic ducts, hepatic arteries, branches of portal vein, hepatic nerves, and lymphatic vessels. We can see here gallbladder, fundus, body, and neck. Then right lobe of liver, porta hepatis, cystic duct from the gallbladder, bile duct, portal vein, hepatic artery proper, caudate lobe of the liver, posterior side, and the anterior side is here, hepatic ducts, caudate lobe, fissure for ligamentous teres, left lobe of liver, and as well as fissure for ligamentum venosum. Gallbladder is pear-shaped sac located in fossa between right and quadrate liver lobes with capacity of approximately 30 to 50 milliliter. It also in contact with duodenum and transverse colon. Consists of fundus, body, and neck. We can see here we have body, fundus, and neck. Then we have cystic duct, right and left hepatic duct can also be seen, common hepatic duct, and then the common bile duct. Same we can see here body, then the fundus, and also the neck of the bladder, gallbladder, right hepatic duct, left hepatic duct. Then we can see cystic duct also. Then we have the pancreatic duct, and then we have common bile duct also going on. Consists of fundus, body, and neck. Fundus is rounded blind and located in the mid-clavicular line. Neck contacts transverse colon. Body is major part and rest on upper part of duodenum and transverse colon. Neck is narrow part and gives rise to cystic duct with spiral walls, Hischer walls. Receives bile, concentrates it by absorbing water and salt, store it, and releases it during digestion. Contracts to expel bile as a result of stimulation by hormone cholecystokinin, which is produced by duodenal mucosa or by parasympathetic stimulation when food arrives in duodenum. Receives blood from cystic artery, which typically arises from right hepatic artery within cystohepatic triangle of Gellert, which is formed by visceral surface of liver superiorly, cystic duct inferiorly, and common hepatic duct medially. Pancreas lies largely in floor of lesser sac, where it forms major portion of stomach bed. Is retroperitoneal organ except for small portion of its tail, which lies in lineorenal or splenorenal ligament. We can see here we have tail, body, and head of the pancreas. We have the pancreatic duct. We have the lobules. We have the gallbladder here. We can see common bile duct. We can see the accessory pancreatic duct. Duodenal papilla is here, and we can also see the C-shaped duodenum. Pancreas is head that lies within C-shaped concavity of duodenum. Tumors are present in head. Bile flow is obstructed, resulting in jaundice. Jaundice occurs when bile pigments, bilirubin, accumulate in blood, giving skin and eyes yellow tinge. Uncinate process is projection of lower part of head and that extends medially behind superior mesenteric vessels. Neck connects head and body of pancreas and lies anterior to junction of superior mesenteric and splenic veins, forming hepatic portal vein. Body extends from neck to tail and is longest part of pancreas. Tail projects towards hilum of spleen. Receives blood from branches of splenic artery and from superior and inferior pancreato-duodenal arteries. Is both exocrine gland, which produces digestive enzymes involved in digestion of fats, protein, and carbohydrates, and endocrine gland, islets of Langerhans, which secretes hormones, insulin, glucagon, and somatostatin. Insulin lowers blood sugar levels by stimulating glucose uptake, glycogen formation and storage. Glucagon elevates blood sugar levels by promoting conversion of glycogen to glucose. Somatostatin suppresses insulin and glucagon secretion. Pancreas has two ducts, main pancreatic duct and accessory pancreatic duct, which carry exocrine pancreatic secretions. Main pancreatic duct or wisdom duct begins in tail and runs to right along entire pancreas, joins bile duct to form hepatopancreatic ampulla or ampulla of Vater before entering second part of duodenum and greater papilla. Accessory pancreatic duct or Santorini duct begins in inferior portion of head and drains small portion of head and body, empties at minor lesser duodenal papilla approximately 2 centimeter above greater papilla. Then duct system for bile passage. Right and left hepatic ducts are formed by union of intrahepatic ductules from each lobe of liver and drain bile from their corresponding halves of liver. We can see also in the figure. Common hepatic duct is formed by union of right and left hepatic ducts, is accompanied by proper hepatic artery and portal vein. Cystic duct has spiral folds, walls to keep it constantly open, and thus bile can pass upward into gallbladder when common bile duct is closed. We can see here we have the greater duodenal papilla, we have the accessory pancreatic duct, and lesser duodenal papilla. Common bile duct is also shown, can be seen here. Common hepatic duct can also be seen here, and cystic duct coming from the gallbladder. Joins common hepatic duct to form common bile duct is common site of gallstone impaction. Common bile duct ductus choledocus is formed by union of common hepatic duct and cystic duct, is located lateral to a proper hepatic artery and anterior to portal vein in right free margin of lesser momentum. Momentum descends behind first part of duodenum and runs through head of pancreas, join main pancreatic duct to form hepatopancreatic duct, hepatopancreatic ampulla, which enters second part of duodenum at major greater duodenal papilla. Bile duct sphincter is circular muscle layer around lower end of duct. Hepatopancreatic duct or ampulla vater is formed by union of common bile and main pancreatic ducts. Sphincter of Oddi is circular smooth muscle layer around the ampulla of major duodenal papilla. Then spleen. Spleen is larger vascular lymphatic organ lying against diaphragm at ribs 9 to 11 in left hypochondric region, covered by peritoneum except at ileum and supported by lineogastric or splenogastric and lineorenal or splenorenal ligaments. It is supplied by splenic artery and drained by splenic vein. Is composed of white pulp. We can see here the white pulp. We can see the red pulp of spleen, which consists white pulp consists of primarily lymphatic tissue around central arteries and its primary site of immune and phagocytic action. Red pulp, which consists of venous sinusoid. We can see here vascular sinusoid or venous sinusoids and splenic cord as it is primary site of filtration. Filters blood, macrophages removes damaged and worn out erythrocytes and platelets, acts as blood reservoir, storing blood and platelets in red pulp, participates in the immune response, protection against infection, and produces mature lymphocytes, macrophages, and antibodies, chiefly in white pulp. Is hematopoietic in early life and later destroys aged, that is worn out red blood cells in red pulp and releases hemoglobin from spent red blood cells. Hemoglobin is respiratory protein of erythrocytes is regulated into globin protein part, which is hydrolyzed to amino acid and reused in protein synthesis. Iron released from heme, which is transported to bone marrow and reused in erythropoiesis. Iron-free heme, which is metabolized to bilirubin in liver and excreted in bile. Celiac and mesenteric arteries. Celiac trunk arises anteriorly from abdominal aorta, immediately below aortic hiatus of diaphragm between right and left crura, divides into left gastric, splenic, and common hepatic arteries. Left gastric artery is the smallest branch of celiac trunk. Splenic artery is the largest branch of celiac trunk, which give rise to the dorsal splenic artery, short gastric arteries, left gastroepipelic or gastromental artery. Then we have common hepatic artery. We have proper hepatic artery, which give rise to right gastric artery, gastroduodenal artery. Then gastroduodenal artery gives rise to two major branches, right? Gastroepipelic or gastromental artery or superior pancreatoduodenal artery. We can see also here different branches of the blood vessels. This is the angiogram from the celiac, showing the three major branches of the celiac angiogram in the celiac angiogram. Superior mesenteric artery rises anteriorly from aorta behind pancreas neck, descends across nucleate process of pancreas and third part duodenum, and then enters root of mesentery behind transverse column to run to root right iliac fossa. It gives rise to following branches, which are inferior pancreatoduodenal artery, medial colic artery, right colic artery, ileocoelic artery, intestinal arteries that are 12 to 15 in number and supply ileum and ileum branch and anastomose to form series of cascade in mesentery. Inferior mesenteric artery give rise to left colic artery, sigmoid arteries, superior rectal arteries, which is termination of inferior mesenteric artery, descend into pelvis. You can see in the diagram, divides into two branches that follow side of the rectum, and anastomosis with medial and inferior rectal arteries. Medial and inferior rectal arteries arise from internal iliac and internal perineal arteries collectively. We can see the branches of superior and inferior mesenteric arteries in this diagram. Then we have hepatic portal venous system. The system vessel limits blood collected from one capillary bed. Intestine passes through portal vein and then through second capillary network, liver sinusoid before reaching inferior vena cava, that is systemic circulation. Portal vein drains the abdominal part of gut, spleen, pancreas, and gallbladder. It is formed by union of splenic vein and superior mesenteric vein posterior to pancreas neck. Inferior mesenteric vein just either splenic, superior mesenteric vein or junction of these two veins. It receives left gastric or coronary vein, carries deoxygenated blood containing nutrients, carries 3 times as much blood as hepatic artery, and maintains higher blood pressure than in vena cava. Ascends posterior to bile duct and hepatic artery within free margin of lesser momentum. We can see here the portal venous system diagram. Superior mesenteric vein accompanies superior mesenteric artery on its right side in root of mesentery. Then we have splenic vein. Then we have inferior mesenteric vein, left gastric or coronary vein. Then we have that drains normally into portal vein. Then we have esophageal arteries that anastomose with esophageal veins of azygous system and lower part of esophagus and thereby enter systemic venous system. We have paraumbilical veins are found in falciform ligament, are visually closed. However, they dilate in portal hypertension. Connects left branch of portal vein with small subcutaneous veins in region of umbilicus, which are radicals of superior epigastric, inferior epigastric, thoracoepigastric, and superior facial epigastric veins. In this figure, you can see the important portal caval systemic anastomosis. Anastomosis occur between these veins, left gastric vein and esophageal vein of azygous system, superior rectal vein and medial and inferior rectal veins, paraumbilical veins and radicals of epigastric, superficial inferior veins, rectoperitoneal veins draining colon and tributaries of renal, perineal, and gonadal veins. Hepatic veins consist of right, middle, and left hepatic veins that lie in intersegmental planes of and converge into inferior vena cava or superior surface of stomach, have no walls, and middle and left veins frequently unite below before entering the vena cava. We can see here the azygous system. We have esophageal and gastric varices. We can see the paraumbilical veins. We have the epigastric veins here. Short gastric veins can also be seen. We have inferior mesenteric veins. Splenic vein is also here. And we can also see the retroperitoneal veins. Kidney, ureter, and perineal gland. Kidney is retroperitoneal and extends from T12 to L3, that is T12 to lumbar 3 vertebra. In erect position, right kidney lies little lower than left owing to large size of right lobe of liver. Right kidney usually is related to rib 12 posteriorly, whereas left kidney is related to rib 11 and 12 posteriorly, is invested by a firm fibrous renal capsule and is surrounded by renal fascia, which divides fat into two regions. Perirenal or perinephric fat lies in perinephric space between renal capsule and renal fascia, and pararenal or paranephric fat lies external to renal fascia, has indentation hilus on this middle portion through which ureter, renal vessels, and nerves enter or leave the organ. We can see here we have cortex, medulla, papilla. You can see the renal column, pyramid, minor and major calyces, renal pelvis, renal sinus, and then ureter. So basically, kidney consists of medulla and cortex containing 1 to 2 million nephrons in each kidney, which are anatomical and physiological units of kidney. So structural and function unit of kidney. Each nephron consists of renal corpuscle found only in cortex, proximal convoluted tubule, renal loop of Hanley, and distal convoluted tubule, has arterial segments including superior, anterior-superior, anterior-inferior, inferior, and posterior segments, which are of surgical importance, filters blood to produce urine, reabsorbs nutrients, exceeds urine, by which metabolic or toxic waste products are limited, and foreign substances, essential oils, and water, regulates salt, iron, electrolytes, and water balance, and produces erythropoietin. Juxtamedullary cells in efferent arterioles wall produces renin. Hormone converts angiotensinogen plasma protein from liver to angiotensin 1, inactive decapeptide, which is then converted in lungs by angiotensin converting enzyme to angiotensin 2, potent vasoconstrictor. Angiotensin 2 increases blood pressure and volume and stimulates aldosterone production by suprarenal cortex, thereby regulating salt, iron, and water balance. Cortex forms outer part of kidney and also projects into medullary region between renal pyramids as renal columns, contains renal corpuscles and proximal and distal convoluted tubules. Renal corpuscle consists of glomerulus capillary tuft surrounded by a glomerular Bowman capsule, which is invaginated bile end of nephron. Medulla forms in that part of kidney and consists of 8 to 12 renal pyramids of Malpighi, which contain descending and ascending tubules, loop of Henle, and collecting tubules. Effects of renal pyramid in papilla fits into cup-shaped minor callus, on which collecting tubules open 10 to 25 openings. Calyces, minor calyces receive urine from collecting tubules and empty into 2 or 3 major calyces, which in turn empty into upper dilated portion of ureter and renal pelvis. Ureter, we can see here, is a muscular tube that begins with renal pelvis, extended from kidney to renal bladder, is retroperitoneal, where it descends on transverse processes of lumbar vertebra and psoas muscle, is crossed anteriorly by gonadal vessels, and crosses bifurcation of common iliac artery, may be obstructed by renal calculi. Kidney stones tend to lodge at 3 anatomical constriction, where it joins renal pelvis, urethro pelvic junction, where it crosses pelvic rim over distal end of common iliac artery, or where it enters wall of renal bladder, that is uretrovesicular junction. Receives blood from aorta, renal, gonadal, common and internal iliac, umbilical, superior, inferior vesical, and middle rectal arteries. Is innervated by lumbar, sympathetic, and pelvic parasympathetic branching nerves. Suprarenal adrenal gland can be seen here. Adrenal gland is peritoneal organ lying on superior medial aspect of kidney. It is surrounded by capsule and renal fascia. Its shape is pyramidal on right and semilunar on left. Has cortex that is essential to life and produces 3 types of steroid hormone in different layers. 3 layers can be remembered through use of mnemonic. Sex outer zona glomerulosa produces mineralocorticoids, mainly aldosterone, salt steroids, aldosterone controlled electrolyte, sodium, potassium, and water balance. Middle zona fasciculata produces glucocorticoids, mainly cortisol and corticosterone. Energy steroids, cortisol controls glucose regulation and suppresses immune response. Inner zona reticularis produces androgen sex steroids. Androgen is responsible for development of secondary sex characteristics and libido in female. So S for salt, E for energy, and X for sex steroids. Has medulla that receives periganglionic sympathetic nerve fiber directly and secretes epinephrine and norepinephrine directly into bloodstream. Receives arteries from three sources: superior splenic artery from inferior splenic artery, medial splenic artery from umbilical aorta, and inferior splenic artery from renal artery, which you can see in this diagram. They are drained via splenic vein, which empties into inferior vena cava on right and renal vein on left. Posterior abdominal wall. So posterior abdominal blood vessels and lymphatics. Aorta passes through aortic carotis in diaphragm at level of T12, descends anterior to vertebral bodies and bifurcates into right and left common iliac arteries anterior to lumbar 4. Gives rise to following vessels: inferior phrenic arteries, medial splenic arteries, inner arteries, testicular ovarian arteries, descends retroperitoneally and run laterally on psoas major muscle and across ureter. Testicular artery accompanies ductus deferens into scrotum, where it supplies spermatic cord, epididymis, and testes. The ovarian artery enters suspensory ligament of ovary, supplies ovary and osmosis with ovarian branch of uterine artery. Lumbar arteries consist of 4 or 5 pairs that rise from back of aorta, runs posterior to spheric trunk, inferior vena cava on right side, psoas major muscle, lumbar plexus, and quadratus lumborum, divide into smaller anterior branches. Then we have medial or middle sacral artery. Then inferior vena cava is formed on right side of lumbar 5 by union of two common iliac veins. Inferior to bifurcation aorta is longer than abdominal aorta and ascends along right side of aorta. Passes through opening of our inferior vena cava in central tendon of diaphragm at level of T8, thoracic 8, and enters right atrium heart. Receive right gonadal, perennial, and inferior veins on left side. These veins usually drain into left renal vein. Receive right and left renal veins. Left renal vein run posteriorly to superior mesenteric artery and anterior to abdominal aorta. Also receive 3 left, middle, right hepatic veins. Middle and left hepatic veins frequently unite for approximately 1 centimeter before entering vena cava. Cisterna chyli is lower dilated end of thoracic duct and lies just to right and posterior to aorta, usually between two crura of diaphragm. Is formed by intestinal and lumbar lymph trunks. Lymph nodes related to aorta. Pre-aortic nodes include celiac, superior mesenteric and inferior mesenteric nodes, which are located around base of cross-splenic arteries, drain lymph from gastrointestinal tract, spleen, pancreas, gallbladder, and liver. Their efferent vessels unite to form intestinal trunk. Para-aortic lumbar or lateral aortic lymph nodes lie anterior to lumbar vertebra beside aorta and drain lymph from kidney, suprarrenal gland, testes or ovaries, upper body and fundus of uterus, and uterine tubes. Receive lymph from common internal and external iliac lymph vessels. Their efferent vessels unite to form right and left lumbar trunks. Nerves of posterior abdominal wall are lumbar plexus that includes subcostal nerve, iliogastric nerve, ilioinguinal nerve, genitofemoral nerve, lateral femoral cutaneous nerve, femoral nerve, which can be seen in the diagram, obturator nerve, accessory obturator nerve, and lumbosacral trunk. Then we have autonomic nerves in abdomen, that is autonomic ganglia, sympathetic chain, that is paravertebral ganglia, are composed primarily by ascending and descending preganglionic sympathetic visceral efferent fibers and visceral efferent fibers which cell bodies located in dorsal root ganglia. We can see that we have dorsal root, we have the ventral root, we have the sympathetic trunk, and we can see sympathetic chain ganglion, greater splenic nerve, and others. In the intestine, we can see here, we have the circular muscles, submucosal plexus, we have mucosa, we have the availability of visceral efferent fibers, we have postganglionic parasympathetic fibers and periganglionic parasympathetic fiber also, and we can also see the vagus nerve here. Also contains cell bodies of postganglionic sympathetic fibers. Collateral prevertebral ganglia include celiac, superior, mesenteric, aortocerial, and aortico, aortico-renal and inferior mesenteric ganglia, which are usually located near origin of their respective arteries, are formed by cell bodies of postganglionic sympathetic fibers, receive preganglionic sympathetic fibers by way of greatest, lesser, and least splanching nerves, as well as some minor contribution from lumbar splanching nerves. Para-aortic bodies are also called aortic bodies. Zucker-Kant bodies or organs of Zucker-Kant or aortic lomera are small masses of chromaffin cells are found near spastic chain ganglia along abdominal aorta. They help regulate respiration by serving as chemoreceptors responsive to lack of oxygen, excess of carbon dioxide, and increased hydrogen ion concentration. Splenic nerves, thoracic splenic nerves. Then we have lumbar splenic nerves. Then we have autonomic plexus, including celiac plexus that contains celiac ganglia formed by splenic nerves and branches from vagus nerve, which receive greater splenic nerves. Then we have, it's also called solar plexus. We have aortic plexus. Then we have superior inferior hypogastric plexus. We have anterior deviant contains of mesenteric or Auerbach plexus, which is located chiefly between longitudinal and surplus muscle layer, and submucosal meson plexus, which is located in submucosa. Both parts consist of postganglionic sympathetic fibers, visceral afferent fibers, and cell bodies of postganglionic parasympathetic nerves. Have sympathetic nerves that inhibit gastrointestinal motility, and secretion, and constrict gastrointestinal sphincters. Parasympathetic nerves stimulate gastrointestinal motility and secretion and relax gastrointestinal sphincters. Then we have diaphragm and its opening. We can see here we have the diagram. Diaphragm rises from signified process, sternal angle part, lower six costal cartilages, costal part, medial and lateral lumbocostal arches, lumbar part, vertebrae number 1 to number 3 for right crusts, and vertebrae lumbar 1 to lumbar 2 for left crust. Inserts into central ternen. We can see here we have central ternen, and its principal function is for inspiration. Receives somatic motor fibers solely from phrenic nerve. Its central part receives sensory fibers from phrenic nerves, whereas phrenic part receives sensory nerves from intercostal nerves. Receives blood from musculophrenic, pericardiophrenik, superior phrenic, and inferior phrenic artery. This sense when it contracts, causing increase in thoracic volume by increasing vertical diameter of thoracic cavity, and thus decreasing the thoracic pressure. Essence when it relaxes, causing decrease in thoracic volume, resulting in increased thoracic pressure. We have right crust is larger and longer than left crust, originates from vertebra lumbar 1 to lumbar 3. Left crust originates from lumbar 1 to lumbar 2, splits to enclose esophagus. Medial arcuate ligament or medial lumbocostal arch extends from body of lumbar 1 to transverse parts of lumbar 1 and passes over psoas muscle and sympathetic trunk. Lateral arcuate ligament or lateral lumbocostal arch extends from transverse process of lumbar 1 to rib 12 and passes over quadratus lumborum muscle. Apertures to diaphragm, we have vena cava hiatus. We can see here aortic hiatus. We have the other hiatus also here. You can see here other muscles, psoas muscle, quadratus lumborum muscle, psoas minor muscle, major muscle, iliacus muscle, and others. So when vena cava hiatus, vena cava foramen lies in central region of diaphragm at level T8 and transmits inferior vena cava and occasionally right phrenic nerve. Epigastric esophageal hiatus lies in the muscular part of diaphragm, right crust at level of T10 and transmits esophageal and anterior posterior trunks of vagus nerves. Aortic hiatus lies behind or between two crura at level T12 and transmits aorta, thoracic duct, azygous vein, and occasionally greater splenic nerve. Then we have the muscles of posterior abdominal wall. We can see here we have quadratus lumborum muscle, we have psoas minor muscle, then we have psoas major muscle. These three muscles are associated with the posterior abdominal wall. Then we have the function of autonomic nerves. Gastrointestinal tract, sympathetic nerves inhibits motility and secretion, contracts sphincters. During parasympathetic nerves, stimulates motility and secretion, relaxes sphincters. Liver and gallbladder promotes breakdown of glycogen into glucose when sympathetic nerves are active. When parasympathetic nerves are active, promotes glycogen storage, increased bile secretion. Spinal medulla uh, promotes epinephrine and norepinephrine secretion while sympathetic nerves are active. They have no effect while parasympathetic nerves are active. Kidneys constrict renal arteries, reduces urine formation. During parasympathetic nerves, action may cause dilation of renal vascular beds. Questions with answers. So first question is abdomen is divided into 9 regions. The first and second are the right and left hypochondriac. Third is epigastric. 4 and 5 right and left lumbar. 6 is umbilical. 7 and 8 right and left inguinal. And 9 hypogastric or pubic region. Muscles of anterior abdominal wall are external oblique muscle, internal oblique muscle, transverse abdominis muscle, rectus abdominis muscle, pyramidalis muscle. Three flat muscles of anterior abdominal wall are external oblique muscle, internal oblique muscle, and transverse abdominis. Two vertical muscles of anterior abdominal wall are rectus abdominis, pyramidalis muscle. Fascia and ligaments of anterior abdominal wall are superficial fascia, deep fascia, linea alba, linea semilunaris, arcuate line, linea semicircularis, lacunar or Gimbert ligament, pactinal or Cooper ligament, inguinal or Popart ligament, iliopactinal arcus or ligament, refracted inguinal ligament, pulsed inguinalis or conjoint tendon, and last is the rectus sheath. Inguinal triangle is also known as Hasselbalch Hasselbalch triangle. Superficial fascia is composed of two layers. Superficial fatty layer is Camper's layer and deep membranous layer that is Scarpa. Two inguinal rings are superficial inguinal ring, deep inguinal ring. Walls of inguinal canal are anterior wall, posterior wall, superior wall, that is roof, inferior wall, that is floor. Roof of inguinal canal is superior wall, that's the roof of the inguinal canal. Three fascia of spermatic cords are external spermatic fascia, cremasteric fascia, internal spermatic fascia. Scrotum consists of thin pigmented skin with darkest fascia. Stomach is divided into four regions. One is cardia, the other is fundus, cardi, and pylorus. Stomach produces mucus, hydrochloric acid, pepsin, and gastrin. Principal muscle of aspiration is diaphragm. Muscles of posterior abdominal wall are quadratus lumborum muscle, psoas major muscle, psoas minor muscle. Fan-shaped double folded peritoneum is termed as mesentery proper. Small intestine consists of duodenum, jejunum, and ileum. Location of complete digestion and absorption of most of products of digestion, electrolytes, and minerals such as calcium and iron is in small intestine. Floor of inguinal canal is inferior wall.